This is our last session. I'm going to be introducing Dr. Patel. So Dr. Patel is an infectious disease clinical pharmacist practitioner at the Edward Hines Junior VA Hospital. She obtained her doctor of pharmacy degree at the University of Illinois at Chicago College of Pharmacy and went on to complete a PGY1 pharmacy practice residency at the Hines VA. She has been an infectious disease pharmacist at the Hines VA for 18 years, as well as the co-director of the facility's Antimicrobial Stewardship program since the inception in 2010. Dr. Patel went on to develop the PGY2 infectious disease residency program for the Hines VA in 2014 and has served as the residency program director since. Dr. Patel's primary research interests include evaluating treatment trends for multi-drug resistant organisms, effects of antimicrobial stewardship efforts on antibiotic utilization, and dental antimicrobial stewardship. So thank you, Dr. Patel.
All right, thank you so much for that introduction, and thank you everyone for attending this last session of the afternoon. I know it's been a long day, but it's my pleasure to be able to discuss with you all antimicrobial stewardship across different healthcare settings. So by the end of this presentation, I hope to have effectively reviewed regulatory requirements for antimicrobial stewardship programs in different healthcare settings, describe impactful antimicrobial stewardship interventions implemented across various healthcare settings, and then discuss both barriers and keys to success in the sustainment of antimicrobial stewardship interventions in these settings. So to start off, I can't stress enough the importance of antimicrobial stewardship being a shared effort. When the concept of antimicrobial stewardship was first introduced, there was a large emphasis on the acute care and the inpatient settings, and the guidelines in the literature really focused on these areas. Over the years, however, the focus has really shifted to outpatient settings as well as other healthcare settings that weren't focused on as much. So areas like the emergency department, dental offices, urgent care, primary care, and nursing homes, long-term care. We know that regardless of whatever setting the patient is in, they all deserve the same level of safe antibiotic use. So I'd like to start off with a review of some of the main antimicrobial stewardship regulations that have been put into place over recent years that provide guidance for different healthcare settings. And I know our speakers this morning did a wonderful job of kind of reviewing some of these regulatory requirements. So I will try to keep it brief and as more of an overview. So starting off with the National Action Plan for Combating Antibiotic-Resistant Bacteria, or CARB. So this national strategy was initially released by the US government in 2014, and it involved 5 interrelated goals to guide federal action. I've listed the goals on the right-hand side of the slide, and the goals pretty much revolve around antimicrobial resistance, as well as strategies to help detect, prevent, and combat it. And then a year later in 2015, the first National Action Plan was released with regular progress reports that followed. Most recently in 2020, the second National Action Plan was released for 2020 to 2025. And this action plan maintains the original goals of the national strategy, but also includes new objectives and targets to help achieve these goals. So following the release of CARB, the Joint Commission subsequently expressed its commitment and developed standards to promote patient safety and quality of care and slow the emergence of antimicrobial resistance. So when the medication management standard was first released in 2017, it focused on acute care settings and nursing homes and listed 8 elements of performance. And then, it lists, 8 elements of performance. And then in 2020, a new medication management standard was introduced that focused on the ambulatory care settings with 5 elements of performance. And then most recently, the acute care standard was updated in 2023, and this now lists 12 elements of performance, some of which are new and some of which have been revised. So I have the elements of performance listed here. The hospital standards on the left-hand side of the slide cover a variety of different areas, including financial resources, leadership, metrics, and data reporting, as well as stewardship strategies. And the outpatient standards, which are on the right-hand side of the slide are more focused on identifying a leader and then working on an annual goal. So all the way from implementation to data collection to analysis of that goal. The Centers for Medicare and Medicaid Services released their final rule addressing antimicrobial stewardship programs in September of 2019. And the final rule addressed antimicrobial stewardship programs, and it was first proposed in 2016 and essentially requires all acute care hospitals and long-term care facilities that participate in Medicare or Medicaid to develop and implement an antimicrobial stewardship program as part of infection control efforts. The requirements of this final rule include components of both effective infection control as well as goals that antimicrobial stewardship programs should be meeting, including coordination of efforts, documentation of evidence-based use of antibiotics, and demonstration of improvements in proper antibiotic use. So I feel like we can't talk about stewardship regulations without mentioning the CDC core elements of antimicrobial stewardship. So this list of elements provides a framework to guide stewardship efforts in a variety of different healthcare settings. And they were first released for the hospital setting. 7 elements were released in 2014 by the CDC. And then these were recently updated in 2019. And then these elements were released for the outpatient settings, so settings like primary care, emergency departments, dental clinics, retail health clinics, and healthcare systems. There's also CDC core elements for other settings such as nursing homes, health departments, as well as resource-limited settings that may lack robust and regulatory frameworks. And so on the CDC site, they state that implementation of elements may vary based on facility staffing and resources, but it's encouraged to implement at least 1 or 2 activities to start, and then to gradually add new strategies from each element over time. And then they emphasize that really any action taken to improve antibiotic use is expected to reduce adverse events, prevent emergence of resistance, and just lead to better outcomes overall. So as many of you in the audience are aware, the CDC offers a plethora of resources and educational materials for both providers and for patients that promote appropriate antibiotic use. And at the Hines VA facility where I'm from, we've used quite a few of these resources and educational materials, particularly during US Antibiotic Awareness Week, which falls every November, where we've posted educational materials in our clinic waiting rooms. And we've also distributed a commitment letter to our patients to ensure that their providers will only prescribe antibiotics when necessary. So if you haven't had a chance to check out the CDC, I highly encourage you to for some of these very useful tools. All right, so now that we've established that antimicrobial stewardship programs are recommended and pretty much mandated in many different healthcare settings, I'd like to shift gears a bit and highlight some impactful antimicrobial stewardship initiatives that have been recently published in the literature. And to do this, we're going to be following a patient on his journey through his various encounters at different healthcare settings. So everywhere from outpatient setting to urgent care, to the emergency department, to the inpatient setting, through transitions of care, and then off to long-term care. And along the way, I'll be highlighting a related stewardship intervention at each particular setting and how the intervention may have impacted our patient's care. So let's meet poor unfortunate JP. He's our patient for today. So JP is a 70-year-old male with a past medical history significant for hypertension, hyperlipidemia, type 2 diabetes, GERD. He's had a CABG ×2 in 2022. BPH and osteoarthritis, who sends a message through the digital patient-provider communication portal with new complaints of malaise, subjective fevers, scratchy throat, and sinus pain that had started a couple of days ago. He's wondering if he would be able to get an antibiotic prescribed to help him feel better. All right, so that brings us to our first intervention that we're going to be reviewing in the literature, and this is in the outpatient setting. And the article is titled Improving Antibiotic Use for Sinusitis and Upper Respiratory Tract Infections, a Virtual Visit Antibiotic Stewardship Initiative. So the issue behind this initiative was the high rates of inappropriate antibiotic use for upper respiratory tract infections. That's unfortunately all too common in several facilities. We see this all the time. The aim of the intervention was to improve guideline concordant antibiotic use associated with sinusitis, cough, and flu. And the setting of the study actually happened to be outpatient e-visits for sinus, cough, and flu symptoms. And in this particular setting, an e-visit involved a patient initiating a request for care. They were then required to complete a questionnaire related to their primary symptom. And then the provider would respond with a written treatment plan within 24 hours. And they had the caveat that if it was a complicated case or a complicated infection, then the patient was referred to their PCP. So the intervention was a bundled stewardship intervention that included multiple components. The first thing that they did was they modified their questionnaire to better assess the patient's diagnoses. And then there were also pre-populated electronic medical record nudges and shortcuts that were created to increase guideline concordant prescribing. And then education was given to all the providers about the intervention. And then finally, there was a direct audit and feedback component by physician champions regarding providers' antibiotic prescribing. So the outcomes that the study authors looked at, they looked at the proportion of inappropriate antibiotic prescriptions as a function of time. And they also looked at patients receiving guideline concordant antibiotics for sinusitis. They used a segmented linear regression on the data pre and post intervention. And I've listed the pre and post implementation periods here on the slide. So moving on to some notable results, there was a little over 5,000 e-visits that were included in the study. And when looking at the percent of visits that resulted in an antibiotic prescription, the authors noted a significant decrease from 43.2% pre-intervention to 28.9% post-intervention. When looking at the number of guideline concordant antibiotic prescriptions for sinusitis, which they considered to be amoxicillin, clavulanate, and doxycycline, they noticed a significant increase from 51.7% pre-intervention to 89% post-intervention. The mean duration of antibiotics also showed a significant decrease from 10 days pre-intervention to 5 days post-intervention. And then the patient follow-up visits within 14 days with their PCP or in the ED where antibiotics were prescribed also decreased significantly from 4.5% pre-intervention to 2.9% post-intervention. And then when looking at the interrupted time series analysis, so the graph on the left shows the proportion of patients with inappropriate antibiotic prescriptions, and then the graph on the right shows the percent of patients that are receiving preferred agents for the preferred duration. And on both of these graphs, there's a black vertical line, and that represents the time of when the intervention took place. And then the gray sort of shaded box represents the time period of when the physician champion audit and feedback took place. And as you can see from both graphs, they certainly saw improvements in both areas after the intervention. But I think the main takeaway point from this graph is that these improvements were even sustained after the end of the physician champion audit and feedback. So this was a successful intervention. They certainly looked at a large cohort of patients. It was nice that they did this interrupted time series analysis because it really gave them the ability to assess the sustainability of improved antibiotic prescribing even after the end of the physician audit and feedback intervention. Some of the limitations that the authors noted, though, is, whenever you're doing multiple interventions at once, you kind of have to question which part of that bundle had the most impact. They did state in the article that if they had to guess, it was probably the direct feedback from the physician champion that probably most likely had the most impact on their results. They also questioned whether there was potential confounding effects from the COVID-19 pandemic just based on the study period. and then also that the accuracy of the diagnoses weren't necessarily assessed. So let's go back to our patient. So back to JP. JP's provider did not prescribe antibiotics, but instead provided some recommendations for symptom management and counseled JP on the untoward effects of unnecessary antibiotics. JP's symptoms didn't change much after a couple of days, and frustrated that he was not able to get his provider to prescribe him an antibiotic, he presented to an urgent care center near his house in hopes of receiving one there. So I think this is a common situation that we tend to see, right? We're moving on now to an intervention in the urgent care setting. And the article title that we'll be reviewing is Utilizing Behavioral Science to Improve Antibiotic Prescribing in Rural Urgent Care Settings. So the issue behind this intervention was similar to the last study, high rates of inappropriate antibiotic use for acute respiratory tract infections. The study authors noted that they were noticing greater than 70% rates of inappropriate antibiotic use at local urgent care centers. So it definitely was an issue they wanted to focus on. The aim of this intervention then, of course, was to improve guideline concordant antibiotic use associated with sinusitis, cough, and flu. This time, the study took place at 3 high-volume rural urgent care centers. And I have the study periods listed here for you. The slide. And this intervention, similar to the last intervention, involved multiple components, but this time they were looking at 3 behavioral interventions. So the first intervention that they put in place was staff and patient education on guideline concordant antibiotic use. And they did this through staff meetings, through emails, lectures, through educational materials on their internal webpage, and then also patient education posted at the different urgent care centers. There was also a component of public commitment where the CDC's commitment letter to our patient template was placed with all of the patient education materials. And then the last component was peer comparison. So this involved feedback emails with prescribing data that was sent to all the providers, and that also included a blinded ranking email comparing them to their peers. So low prescribers were considered those that prescribed less than or equal to 23% of antibiotic inappropriate prescriptions. And then high prescribers were those that prescribed greater than or equal to 45% of antibiotic inappropriate prescriptions. And the way that the authors figured out these percentages was they used the national rate of antibiotic inappropriate prescribing for acute respiratory tract infections among urgent care centers in the United States. So that rate happened to be 45%. And then they calculated that if they were to see a 50% decrease, that would result in a percentage below 23%. So that's kind of where they got that cutoff for low and high prescribers. The primary outcome of the study then was the proportion of antibiotic inappropriate acute respiratory tract infection diagnosis visits that received an antibiotic. And they also did an interrupted time series analysis that compared antibiotic prescribing over a 16-month period pre and post intervention for a total of 22 months. So turning over to the results, there were close to 12,000 antibiotic prescriptions that were included in the study and close to 18,000 acute respiratory tract infection encounters. So again, a very large study. The primary outcome, which again was looking at antibiotic inappropriate prescribing, showed a significant decrease from 72.6% pre-intervention to 57.7% post-intervention. The authors calculated that there were about 981 inappropriate prescriptions that were averted because of their interventions. And when they looked at the data a little bit closer, they found that the largest difference was seen when they compared the time periods between April of 2018 versus April 2019, where they saw a decrease from 71.8% pre-intervention to 46.1% post-intervention. And just to kind of put this in perspective, that these time periods were post-flu season, and they also happened to be around after the second round of peer comparison emails that all the providers received. So when looking at the interrupted time series analysis, again, they saw a significant decrease, 70% pre-intervention to 56.9% post-intervention. And they noted that the mean percent of antibiotic inappropriate prescribing decreased an additional 2.6% after the intervention was completed. So again, compared to the last study, another successful intervention. Again, they looked at quite a few prescriptions and patients in the study. They mentioned that they did some randomized chart auditing during the pre-intervention period. And so that's always good because that increases the accuracy of the data. And I thought it was neat that they used national benchmark cutoffs to determine low versus high prescribing because they didn't have that, that data locally. In terms of some limitations, again, it was, it's hard to determine which intervention had the largest effect since they were all sort of implemented at the same time. And the authors also did not assess specific factors that may have influenced prescribing. So things like patient demographics, provider characteristics, and the time of the day or the week, these could all have potential confounding effects. All right, so back to our patient. So JP unfortunately strikes out again. The provider that saw him at the urgent care center remembers receiving peer comparison reports last year and thinks that his antibiotic prescribing may still be actively monitored. So he had been considered a high prescriber when compared to the other providers, which made him reevaluate his prescribing practices when managing respiratory tract infections. He noticed that patients seemed more amenable to not receiving an antibiotic when he reviewed the patient commitment letter with them that is now hanging in all of the treatment rooms. So JP was upset at first, but then also realized that he didn't want a whole new set of problems if he were to develop an adverse reaction to an antibiotic that he might not even need. So he followed the symptomatic management instructions and started feeling better within a week. Surprise, surprise, right? If you just wait a couple days, you're going to start feeling better. Okay, unfortunately, JP can't catch a break. So 6 months later, JP presents to the emergency department of a nearby hospital due to an acute onset of gait imbalance that's accompanied by vertigo. His symptoms had already been present for several hours before his admission, and on exam, he was found to be confused and complaining of a headache. The ED provider completes a workup, including sending off a urine culture in the event that an infection may be causing JP's confusion. The urinalysis returns with the following results while the urine culture is being worked up. So as you can see, JP's urinalysis is on the left-hand side of the screen. He has negative nitrites, negative leukocytes in there, 0 to 5 white blood cells. His urine culture is pending, and the ED provider orders a dose of ceftriaxone just in case until a UTI can be ruled out. And this, unfortunately, the ceftriaxone gets continued for this patient upon admission. So as you maybe guessed, we're moving on to a stewardship intervention in the emergency department setting. And this is actually kind of a shameless plug for my own facility because this is a study that we conducted at the Hines VA hospital. And the title of the article is Evaluating the Impact of a Urinalysis to Reflex Culture Process Change in the Emergency Department at a Veterans Affairs hospital. So the issue that we were facing was, and unfortunately all too common issue, was the inappropriate urine culture ordering that we were seeing and then subsequent treatment for asymptomatic bacteriuria, and particularly in our ED emergency department setting. So the aim of our intervention then was to decrease the ordering of urine cultures when it wasn't clinically necessary in order to reduce some of this inappropriate asymptomatic bacteriuria treatment. And so this study took place at an emergency department at about a 500-bed VA hospital. And I have our study periods listed here. And so our intervention involved creation of new order sets in our electronic health record for urinalysis and urine culture ordering. And so the providers, when they would order a urine culture or a UA, they had 3 choices. They could order a UA only. They could order a UA with a urine culture that would be canceled by lab personnel if the UA had less than or equal to 5 white blood cells. Or they could order a UA with a urine culture that was designated as do not cancel, where the urine culture was processed regardless of whatever the UA results showed. So we did put some guidance on the order screen for when this option was appropriate. So specifically for GU, patients undergoing GU procedures, pregnant patients, these patients, regardless of whatever the urine culture goes, we're interested in seeing that. So these were just examples of when a do not cancel might be appropriate. And then we also provided provider education on these new order sets so that everybody was aware. Our primary outcome was looking at the frequency of inappropriate urine culture use and inappropriate antibiotic prescribing pre and post implementation of this new UA to reflex culture process change. And then our secondary outcomes focused on safety. So we were looking at subsequent visits for UTI, specifically in the group where the urine cultures were canceled. We included all ED patients who received a UA with or without a urine culture. And we excluded patients that were admitted for inpatient care if they were receiving concurrent antibiotic therapy for a non-UTI indication, if they had duplicate cultures, or if they had chronic bladder management devices. And so in terms of some notable results, we looked at a total of 684 urinalyses, 429 pre-intervention, 255 post-intervention. Looking at our primary outcome, we found that urine culture processing, despite a negative UA, decreased from 100% pre-intervention to 38.6% post-intervention, which was significant. So essentially, before we put this process into place, all providers were ordering a UA with a urine culture. That was just kind of how it was ordered in our electronic health system. When looking at antibiotic prescribing then for asymptomatic bacteriuria, we also noticed we found a significant decrease from 10% pre-intervention to 1.2% post-intervention. And then when we looked at the patients that had a negative UA, we found that antibiotic prescribing had decreased by 25%. In terms of secondary outcomes, there were no reports of UTI-related visits within 7 days of urine culture cancellation. And so, again, this was, we were really happy to see these results. This was a success for us. And this certainly isn't a novel process by any means. There is a great deal of data in the literature that supports these types of UA to reflex culture processes. But it was fairly easy to implement, and we found it to be effective and safe. So for us, that was a win. In terms of a potential limitation, though, the recognition of a negative UA and then subsequent cancellation of the urine culture was dependent on lab personnel. So this wasn't necessarily an automated process, but the lab personnel would have to manually cancel that urine culture. So that can always lead to human error. In terms of future direction, though, we're currently looking at increasing our white cell cutoff in the UA to 10 white cells. There's supporting literature that, that supports this. And, we hope to optimize our cancellation rates of our urine cultures even further. So I think the key behind this intervention is this phrase, if you don't see it, you won't treat it. Naturally, providers are going to be less influenced to treat when there is no positive culture. And so I think that this really supports that notion. All right, so back to our patient. So JP's urine culture that had been sent from the emergency department ended up returning negative, surprise, surprise. However, JP had continued on the ceftriaxone for 48 hours before the team received those results. During this time, JP developed a rash, thought to be due to the antibiotic, and this was then documented in his chart. So very unfortunate, but very real situation of untoward consequences that can occur when we're prescribing unnecessary antibiotics, even if it's just for a couple of days. You might think too, like maybe if the provider hadn't seen the urine culture pending, it's possible that they could have discontinued the antibiotic right away. All right, so upon further workup of JP's symptoms on admission, a brain MRI revealed ischemia of the right cerebral hemisphere. And in the next 48 hours, JP gradually became unresponsive. A brain CT revealed acute obstructive hydrocephalus. And so as a result, JP was transferred to the ICU. He was intubated, and then an external ventricular drain was placed. Perioperative antibiotics were administered and continued until the EVD was removed 7 days later. So now we're moving on to a stewardship intervention in the inpatient setting. And the title of the article that we'll be reviewing is The Effects of Avoiding Extended Antimicrobial Drain Prophylaxis on Clostridioides difficile and post-procedural infection rates, a 5-year retrospective. So the issue behind this intervention was that peri-procedural antibiotics are unnecessarily continued for extended periods while surgical drains remain in place, and this can lead to untoward consequences. The aim of the intervention was to evaluate whether shortening the duration of antimicrobial prophylaxis could decrease the incidence of C. difficile infection without increasing the incidence of post-procedural infection. The study took place at a 619-bed tertiary care hospital over a 5-year period. And again, I have the study periods listed here. And the intervention involved a practice change that occurred in May of 2017. So the old practice at this facility was that the post-procedural drain prophylaxis was continued for the duration of drain placement or for the duration of the EVD. And the new practice then limited this post-procedural drain prophylaxis to a maximum of only 24 hours after surgery, or only 1 dose of pre-op antibiotics for EVD placements. And then in the facility, they also created default perioperative orders with standardized antimicrobial agent and dosing regimens that they implemented. The primary outcome of the study was the incidence of hospital onset C. difficile infection within 90 days of a neurosurgical procedure. And the secondary outcomes looked at post-procedural infections, so specifically surgical site infections, EVD-associated meningitis, and ventriculitis. So the study involved a little over 7,000 unique patients who underwent about 8,500 surgeries, so quite a large cohort. There were about equal numbers, around 3,000 or 3,500 patients in the pre-implementation group and the post-implementation group. And there were a total of 413 EVD placements. So when looking at the primary outcome, which again was the incidence of C. diff infections within 90 days of the procedure, the authors found a significant decrease from 23 cases pre-intervention to 3 cases post-intervention. And they calculated an absolute risk reduction of 0.52% and a relative risk reduction of 85.2%. In terms of the secondary outcome, they did not find any difference in the incidence of surgical site infections per procedure, nor did they find any difference in the incidence of EVD-associated infections. So the authors concluded that limiting antimicrobial post-procedural prophylaxis to only 1 dose at the time of EVD placement or 24 hours post-operatively was associated with a significant decrease in the incidence of C. difficile infection. So limitations of this study was, 1, its retrospective nature. Also, there could have been unidentified factors that changed over time that could have independently influenced C. difficile or the post-procedural infections. So specifically, the authors were referring to potential infection control efforts that maybe were put into place during the study period. However, as a strength, I think this was a great study. It really provides support to help debunk a commonly occurring practice that we see in our facilities that can result in excessive antimicrobial use. All right, so back to JP. 48 hours after antibiotics were discontinued, JP develops multiple bouts of watery diarrhea with an increase in white cells to 19. His baseline was 10, as well as some hypotension. Stool tests were sent and confirmed C. difficile infection, and JP was started on 10 days of oral vancomycin. So he strikes out again, right? So as we know, even a couple of extra days of antibiotics can lead to adverse events like C. difficile infection, and this can be a huge setback to a patient's recovery. All right, so unfortunately, during the hospitalization, JP also was diagnosed with a UTI for which he was prescribed a 7-day course of ceftonir. And due to severe deconditioning from the subsequent prolonged hospitalization, JP was to be transferred to a nursing home for rehabilitation. So today, the patient is on day 5 of the ceftonir, and he's going to be discharged to long-term care. The medicine resident, however, orders a 7-day course of antibiotics for his UTI after kind of quickly reading the treatment plan and the notes. So let's move on to a more unique area for antimicrobial stewardship that's receiving more and more attention, and that is in the setting of transitions of care. So the article that we'll be reviewing is titled Pharmacist-Driven Transitions of Care Practice Model for Prescribing Oral Antimicrobials at Hospital Discharge. And the issue behind this intervention was the fact that there's prolonged duration of antimicrobial therapy at hospital discharge. This can be problematic, and we really need antimicrobial stewardship resources in this setting. So the aim of this intervention was to evaluate a pharmacist-driven intervention that was designed to improve the selection and duration of oral antibiotic therapy that was prescribed at hospital discharge for common infections. The study took place in 17 distinct medicine, surgery, and specialty units, and these were all within 1 academic tertiary hospital and 4 community hospitals. So a total of 5 hospitals were included. And so for their intervention, they had their clinical pharmacists identify patients that were going to be discharged with prescriptions for oral antibiotics for some select common infections. And then they used a multidisciplinary rounding model to discuss, document, and then facilitate order entry of these antibiotics. So these are pharmacist-entered orders that were signed by the provider. And so their primary outcome was a frequency of optimized antimicrobial prescriptions at discharge. And then they also looked at safety endpoints like adverse drug events, 30-day unplanned office or emergency department visits, 30-day readmissions, and also 30 and 90-day mortality rates. They included all adults that were admitted to one of their study wards and discharged with oral antibiotics for one of the following types of infections. So they tried to pick infections that had more clear guidance in the national guidelines for duration of therapy. So they looked at urinary tract infections, respiratory tract infections, skin soft tissue infections, as well as intra-abdominal infections with adequate source control. They excluded patients who were pregnant if they were discharged on IV antibiotics, if they were diagnosed with cystic fibrosis, endovascular or CNS infections, osteomyelitis, or febrile neutropenia. So this study looked at a total of 800 patients. There were 400 patients pre-intervention and 400 patients post-intervention. And when looking at their primary outcome of optimal antimicrobial prescription at discharge, they found a very nice increase from 36% pre-intervention to 81.5% post-intervention. And they identified that the largest contributing components to this increase were the reduced durations of therapy, the increase in appropriate antibiotic selection, and then the decrease in the treatment of asymptomatic bacteriuria. They also noticed that the increase in optimal prescribing was consistent in both the academic center as well as the community hospitals that they looked at. In terms of safety outcomes, they didn't find any differences in readmission rates or mortality, and they found that the intervention was associated with fewer adverse drug events. So they found a decrease of 9% pre-intervention to 3.2% post-intervention. So the authors of the study concluded that a pharmacist-led discharge stewardship intervention was associated with improved antimicrobial prescribing during transitions of care. In terms of some limitations, they did use a non-randomized design, which could potentially lead to biases. But they also used a step wedge design with multiple observation periods and points of intervention. And so this may have mitigated some of those biases. Another limitation is that communication models may have differed depending on the type of hospital. So a multidisciplinary rounding system may look very different in a community hospital compared to an academic facility. However, in terms of strengths, this was a well thought out intervention. The authors stated that they ensured buy-in from all key partners involved to promote ownership and accountability. And I think this is always a key to a very successful intervention. And this intervention, targets a unique but very important area, leading to increased quality of care and patient safety. So I think it's an area that we sometimes forget about, but I think more and more I guess they're just highlighting it more and more in the literature, and they're bringing more and more focus to it. All right, so back to JP. The clinical pharmacist that's rounding with JP's medicine team regularly reviews outpatient antibiotic prescriptions for the patients on his team getting discharged and happened to catch the prolonged duration of ceftonir. So this pharmacist was able to intervene and change the days of therapy from 7 days to only the remaining 2 days that JP had left. So go pharmacy. That was a solid intervention and just an example of what antimicrobial stewardship interventions can do for these patients. All right, so JP is off to his next adventure. So during his nursing home stay, because he was transferred to the nursing home, JP did well and started improving slowly. On day 14 of his stay, he started to complain to his nurse about some abdominal discomfort, thinking that it may have been due to something that he had eaten the night before. His repeat labs were stable, but as a precaution, the nurse collected and sent off a sample of JP's urine just in case he was developing a UTI. So this is kind of happening to him again, unfortunately. All right, so let's end JP's journey with one more study, and this one is in the long-term care setting. So this article is titled "A Multifaceted Antimicrobial Stewardship Program for the Treatment of Uncomplicated Cystitis in Nursing Home Residents." And the issue behind this intervention is that asymptomatic bacteriuria is frequently and inappropriately treated with antimicrobials in the long-term care setting, potentially leading to all these untoward consequences like antimicrobial resistance, adverse drug reactions, and C. difficile infection. The aim of this intervention was to determine the association of a multifaceted antimicrobial stewardship and quality improvement intervention with the reduction in unnecessary antimicrobial use for unlikely cystitis among non-catheterized nursing home residents. So the setting of the study involved 25 nursing homes all around the United States. And I have the study periods listed for you here on the slide. And in terms of the intervention, so the intervention was essentially taking all the nursing homes that participated in the study and putting them into 2 different groups. So first, there was a group of the intervention nursing homes. So there was a total of 12 nursing homes that were the intervention nursing homes. And these nursing homes received the following. So the intervention nursing homes received additional webinars, pocket-sized educational cards, tools for system change. They got some educational clinical vignettes, monthly coaching calls, all related to appropriate treatment of cystitis in the nursing home setting. And then the control nursing homes, which there were 13, just kind of went on with their usual care. So they didn't receive any of these interventions. But all facilities received quarterly feedback reports. So the primary outcome of this intervention or of the study was the incidence of antibiotic treatment for unlikely cystitis cases. And the secondary outcomes looked at overall antibiotic use for any UTI, as well as some safety outcomes like C. difficile infections, all-cause hospitalizations, and death. So there were a total of 25 nursing homes that participated in this study, and the number of resident days per nursing home, per group was fairly large and pretty equal. In terms of the primary outcome of looking at the incidence of antimicrobial use for unlikely cystitis, the authors found a 27% lower rate in the intervention versus the control group. In terms of secondary outcomes, overall antibiotic use for any type of UTI was found to be 17% lower in the intervention versus control group. The C. difficile infection rate was 65% lower in the intervention versus control group. And there was no differences found in all-cause hospitalization and in all-cause death. So the authors concluded for the study that a low-intensity, multifaceted quality improvement intervention was associated with a reduction in risk of inappropriate treatment of unlikely cystitis cases and an overall antibiotic use for UTIs. In terms of some limitations, the facilities weren't necessarily blinded, so that could bring up the issue of performance bias. The facilities that were receiving all these additional interventions, maybe they felt like they had to change their practice. And then the authors relied on self-reporting from facilities rather than direct data collection. So there's always room for some accuracy of data with that. And then also they noticed that the majority of the participants that participated in these coaching calls, they all happened to be pretty much nurses. So there really weren't a lot of providers or pharmacists that participated in these calls. However, as a strength, I think it was kind of neat that they included a control group in this type of study where they had control nursing homes and intervention nursing homes. So I thought that was creative. They included facilities from across the country, which was nice to see. And then they involved practical tools that can be easily integrated into common workflows. So things like webinars and pocket cards and, coaching calls, these are all things that could potentially be integrated into your daily workflow. Okay, so one more look at JP before we bid him farewell. JP's urine results returned with an insignificant amount of Staphylococcus epidermidis, but antibiotics had not been started. The nursing home had recently received quite a bit of education and guidance on the appropriate management of cystitis and the harms that could be associated with inappropriately treating asymptomatic bacteriuria. The physician at the nursing home had advised against starting antibiotics and to monitor JP clinically, especially in light of his recent bout of C. difficile infection. So JP's abdominal discomfort had subsided within 24 hours, and after successful rehabilitation, JP was discharged from the nursing home a week later. So a little too perfect. I think when I was making this case, I was like, okay, this, this would be in a perfect world, but good for JP. He was able to return home. So to round out this presentation, I just want to talk briefly about some barriers as well as some keys to success when we think about antimicrobial stewardship interventions. We saw a lot of different types of interventions within the studies that I discussed, and the literature has really shown that some interventions can lead to more sustainable outcomes than others. So what actually works and what doesn't? All right, so first and foremost, looking at some potential barriers. First off, tackling too many issues at once. And I think the speaker before us kind of hit on this point as well. But, it can be extremely overwhelming when your stewardship team is trying to make improvements in a lot of different areas. And so it's really important to provide or perform a needs assessment initially to identify what are your priority areas for your institution. And it's okay to start with low-hanging fruit. So things like potentially restricting an antibiotic that you might see as being used excessively or unnecessarily, or even implementing something as impactful as a reflex urine culture process that I had described through a hospital policy. It doesn't require much legwork once the process is in place, but the benefits can be very far-reaching. The next barrier that a lot of us may face is dealing with resistant providers. So it doesn't, matter how awesome and amazing our intervention is or our recommendation is, if the provider you're dealing with is not willing to accept your recommendation, then it doesn't really make a difference. And so resistant providers can be due to various reasons, including clinician knowledge deficits, or simply just reluctance to change practice because they've been practicing a certain way for so long. The next potential barrier is limited access to antimicrobial prescribing trend data. We talked about how metrics used to be pretty hard to obtain, and it's become easier through dashboards and some other, advances in our informatics and just, technology. And you need this data in order to follow the trends to identify potential interventions and to assess the success of these interventions. And then short-term interventions without any follow-up. And we've certainly seen this at our facility where we might implement an intervention and things go great for a few months, but then if there isn't any follow-up or any accountability, then practice can return to its old ways. So it's really important to follow up with, sharing results from your intervention, if you have data to share, and just kind of keeping up with education. I feel like repetition can really lead to change. And then, unfortunately, lack of resources and time, which can be a common barrier at many facilities. So what are some keys to success then? What can we do when we're facing some of these barriers? So first off, setting attainable goals. So really work with the resources that you do have. and focus on evidence-based fundamental antimicrobial stewardship interventions. So really focusing on those interventions that have been shown in the literature to have a high impact. So things like prospective audit and feedback when you're looking at antimicrobials, prior authorization, and behavioral interventions. These have all been shown to be very impactful. And we saw this when we were discussing the urgent care study that looked at these behavioral interventions. Next off, engaging your frontline clinicians. So engage your frontline providers when you're selecting and implementing new antimicrobial stewardship interventions. Also when you're creating facility treatment guidelines. And don't forget about your specialty providers too. So, you know, providers in areas like critical care and transplant, it's so important to include them when you're co-developing care pathways, because collaboration can really help influence prescribing in some of these really difficult to treat patients that are often subjected to broad spectrum antibiotics. And then integrating antimicrobial stewardship team members into multidisciplinary rounds is found to be very successful and impactful. And this is so much more effective than a provider receiving a call or a message from a faceless pharmacist, right? Sometimes we're just using like electronic chat, you know, functions, or we're paging or calling, but in-person communication can be so much more powerful. And we saw this working successfully in the transitions of care study that we reviewed, where the clinical pharmacist was, you know, front and center on rounds and was able to make recommendations right there. All right, and then probably one of the most important keys to success is sharing your data. So providers will be interested in seeing their own data, and it's just human nature to be curious about how you compare to your peers. And these peer comparisons can be very motivating to change practices. We saw this with the urgent care study again, where we were looking at you know, peer comparisons and behavioral interventions. So again, it's the behavioral interventions, accountable justification. These have been the stewardship interventions in the literature that have really been shown to be effective. And then finally, implementing antimicrobial stewardship interventions across the continuum of care. So opportunities to improve antimicrobial prescribing occur throughout a patient's healthcare journey. And we saw this with our patient, JP. It's just as important to focus on antimicrobial stewardship efforts in the inpatient setting as it is for the outpatient setting and during settings like transitions of care. So in summary, this is certainly not a race, it's a marathon. Successful antimicrobial stewardship certainly takes time, but with continued efforts, we will get there. And with that, I'm happy to take any questions. I actually like this so much, I put this on a t-shirt.